live. I'm with Dr. Dan Doleys. Dan, thank you so much for doing this today.
My pleasure.
I've worked with Dr. Doleys for really over 20 years, and I've asked some of my associates to sit in and listen to what you have to say. I don't mean to sound overly solicitous to you, but you are one of the best speakers I've ever heard on a national level. So I'm really honored that you sit with us today. Dan is a psychologist that specializes in chronic pain, and he's written a couple books. These are just some of his books that he's written on pain and how to live with chronic pain, I'd say. And so really one of the country's, I think, experts when it comes to talk about the psychology of pain and how to live with chronic pain. Dan, thanks again for coming. A lot of people will catch this on the rebroadcast, and once again, I'll just put a shout out if you've got questions. Hopefully, Dan can answer them. Or what's your website?
It's www.doleysclinic.com.
Doleysclinic.com. Before we started, you were showing us some interesting things about pain in terms of the biology of living systems. Could you back up and start telling us a little bit about that?
I will. My interest has been in exploring the nature of pain. And according to the ISP definition that everybody is accustomed to, pain is an emotional sensory experience, and it is associated with actual or potential tissue damage and described in those terms.
Let's slow down just a little bit. I think the listeners need to hear that there doesn't have to be any damage to the tissues to cause pain.
That's correct, and as a matter of fact, some of your viewers may be aware of this, but historically we have classified things as nociceptive pain, meaning bone, tissue, and so forth, neuropathic pain related to nerve damage. Some have included inflammation as another category, but in the last year or two there is now a nociplastic pain, which is a term that is being introduced to help to explain or describe things like fibromyalgia, where there is no apparent activation of the peripheral system, but yet it's very clear that pain exists. Now, for me, there's some other issues worth looking at. It is hard for me to conjure that the experience that a 26-year-old fetus has, and we've done some talks, and other people have in terms
26-week-old?
26-week-old.
Okay.
The Congress has said, they have adopted it, that at 26 weeks they declare that fetus experiences pain. Now, to use the term pain and have it apply to a 26-year-old fetus,
week-old,
26-week-old, and the same thing to a child who is 10 years old and got injured, to a 21-year-old who has an accident, to a 44-year-old who's had 2 back surgeries, to a 65-year-old who's got arthritic changes, seems to me to be a stretch. So several years ago, I got interested in just philosophically exploring the concept. And I don't think there is anything that is, quotes, wrong with the ISP definition, but I think it's intriguing to look at pain in the context of these different sorts of systems. So that led me into some interest in realizing that we may need to get out of our traditional scientific mode. And that was what Isaac Newton brought to us. And what Newton brought to us was, number one, materialism. And number two, reductionism. Now, materialism means that if you can't measure it, it doesn't exist. The only things that exist are those things that you can measure, that you can see, you can touch, and so forth. And reductionism indicated that the way to understand something is break it down into its essential parts, and then you put those parts back together, and that's how you understand a living organism or anything mechanical. So these elements of reductionism and materialism have served our scientific purposes very, very well. But they don't apply at another level. At a nuclear level, at a quantum mechanics level, you have gluons and quarks, and Polkinghorne over in England, a theoretical physicist, has indicated the term, these things have to be there. Nobody's ever seen them. Nobody's ever measured them. But they have to be there for things to work the way they do. If these things aren't there, these things don't work. So he has used the term unseen realities. So they are there, but nobody has seen them, nobody has measured them. We know what they're supposed to do and how they're supposed to act. So those are things that kind of got me curious about looking into some other aspects of pain and how there might be other dimensions of pain that might be interesting to conceptualize. So in the book, the first one on dynamics, complexities and dynamics of pain.
This is
that one took. That's really a research book. It took about 7 years to gather the material together and put into that book. And that book kind of is the beginning of exploring some of these concepts. Now, to help to illustrate what some of this looks like.
Yes.
I have a couple of slides here that may help to.
Tran, you might want to get real close to the computer now.
Now this is migrating birds, my starlings, and if you pay attention, it appears as though they change shapes and size, but it appears as though they kind of move in unison. It's very difficult, if you look at this, to find out where is the leader of the pack.
Right.
They seem to turn in unison. They seem to turn in a ways that nobody's falling out of the sky. Nobody is bumping into anybody. There has to be some type of communication, and this is called non-local action. And physicists have actually demonstrated that things that are a long distance away, hundreds of miles away, change simultaneously. There appears to be no connection, but there's something there. So of pain, when we look at things going on in the brain, is there may be simultaneous changes in the brain, and we tend to associate emotions with sensitivity and with sensory aspect. So maybe those things change simultaneously. We like to think of things going from one place to another, to another, to another, but perhaps someplace in there they change all at the same time. And there may be things outside the brain that are impacting the facts or changes in the brain.
So how do you apply these birds flying like that, like in a very systematic way, yet no locus of control, to a patient? What is the connection to your patients?
It's a good question. The connection is this. Everybody, at least most people at this point, understand that pain ratings may not tell us much, especially in a chronic pain situation. There are people, I'm sure you've seen them, I've seen them, who come in and their pain ratings are 7, 8, or 9, which is traditionally high. They don't appear to be
in distress.
And you have people with pain ratings at 2, 3, and 4, which is low.
But they appear in great distress.
Sometime, or they also appear in no distress. So here these numbers are. You have people with the very same numbers that look exactly alike, and people with different numbers that look alike. And as a matter of fact, it's gotten to the point now that some of the organizations that years ago adopted this notion as pain as the 5th vital sign,
right,
has backed off.
So your point then is, in some ways, we can't quantify pain, and we need to somewhat leave that aside and look at more of the whole picture as opposed to just a number.
That's part of it. The other is we are interested in function. You know, when I talk to patients, I rarely talk about pain. And I tell them, and they're sometimes surprised about it, is I'm not concerned about that.
Right.
What I'm concerned about is their life. Are they getting out and exercising? Have they got back on their smoking? Have they been able to go out with a family member and enjoy a meal? Have they been able to go to their grandson's football game and sit in the stands? Are they doing some stretching? Having done this now, and we just celebrated our 40th year of doing this, I can tell you with absolute certainty, the people who do the best with chronic pain long term are not the people with the less pain. They are the people who have the most satisfying quality of life in spite of the pain they have, because to date, unless something different, I don't know of anything that anybody has come up with that says is a cure for chronic pain. That if you do X, Y, and Z, your pain will go to zero and your life will return to the way it was beforehand. So this has also led us, along with many, many other people, to begin conceptualizing pain as a chronic disease process. In that sense, it is no different than diabetes. And that's important for the patient to understand, because with diabetes, if you give them insulin and the patient gains 30 pounds, you're going to fuss at them. And you're going to say, now, my insulin isn't going to do much for you if you don't watch your diet, if you don't exercise, you don't lose weight. And this is the nature of chronic pain. We can give them pain medicine, and sometimes too much and for too long. But the point is that unless they get involved and unless they're involved in participating. So several years ago, we looked at function, and what we found is if you change things in the emotional part of the person, the depression, you can change depression, you also change anxiety, frustration, irritability. But it doesn't necessarily change functioning. Now, in the function realm, if you get people exercising, it seems to spread over into going out to dinner, going out for a walk. It seems to spread into other areas. So this is where this non-local, you can take the whole area of functioning and change one aspect of it, and it seems to spread into other areas. So you don't have to change each individual little thing. So the way this applies to patients for me is, if you start doing certain things in this area, it will bleed over into other areas. And that's what we have to look at. So we are very big on getting people to exercise. It doesn't take much. I know this guy, for example, he tells his patients, when you're watching television, and we have people that are very, very large people, it'd be hard for them to exercise. So he says, every time the commercial, just stand up and march. Stand up during that 2 minutes of the commercial and march in place. When the commercial is done, sit back down.
There you go.
You do that during 2 1.5-hour programs, and you have exercised 20 some odd minutes. So over time, that just starts accumulating. So the way this non-local thing works is getting them to realize and getting them to move in one direction. And what we now know is if you move pain, you don't necessarily move other things. If you move function, you start moving other aspects of it.
I tend to say you have to figure out a way to function in spite of your pain.
Exactly. Now,
you have some other images to show us?
This is what is called a complex adaptive system, and this comes out of systems theory. Now, if you pay close attention to right here, you will see something emerge from there. And there is a caption with it, and this is this is a certain type of octopus.
Wow.
And he will speed off because he's been startled. Now, to make the point a bit more, the people who did this, David Gallo, will now do it in reverse because he wants people to appreciate. Now, watch what happens as this animal reattaches itself to this wreath. He will then become the same color, the same texture, same size. He basically becomes invisible and blends in. And this is a complex adaptive system. Now, where that relates to pain is we're constantly changing. We're sitting here talking right now, and these gentlemen are here. So as we sit, we're going to get a little sore. We're going to twitch a little bit. We're going to move a little bit. We adjust. We adapt. Our system probably never reaches complete homeostasis, where it is completely at ease. It's all the time doing something. Now, in the sense of chronic pain, the less the individual is involved in things, the less pliable and flexible and adaptive their system becomes. They become deconditioned, they have inflammatory processes, their muscles become stiff and sore, and pretty soon, any attempt to do anything becomes very, very uncomfortable. So the system loses its ability to adapt, but it wants to adapt. That is our nature, is to adapt and change and adjust. And that's part of the reason why it is very important to get involved with people with chronic pain very early on. And it's part of what you folks do. One of the reasons you do procedures is you want people to get up and get going and be moving, trying to reestablish some of that homeostasis, trying to reestablish some of that activity. And the patients you love to see most are the ones who come back, and they may come back 6 or 7 months later and say, Dr. Goodman, I'll tell you, after that block, it took a couple of weeks, But it started to hit in, and I started gradually doing more and more, and then it wore off in a couple of months, but I still kept going, and now I think I may need an updated one. I mean, that is the ideal folk for this.
We definitely want to break that cycle of pain.
Break that cycle, and once they get going, so our systems need to adapt. Now, my son is finishing an ebook, and it'll be published, and it's about pain-free lifestyle, and he's very much into nutrition and supplements. So he's got diets, he's got recipes, he's got everything in there about what people can do to suppress inflammatory processes. And most of what we have right now doesn't affect underlying cause of inflammation. When pain comes around, it releases and activates microglia, and even pain medicine will activate microglia, which stimulates release of inflammatory substance, cytokines, and this produces a lot of inflammation and what some people call then opioid-induced hyperalgesia. The patient becomes increasingly sensitive to the medicine that is supposed to make them less sensitive.
So what you're describing are changes that are occurring inside the brain at a microscopic level.
Inside the brain, but also in the entire system. You know, the brain is part of that. And it's interesting that when we talk about this, and this is the other fascinating thing about it, is Melzack, of great fame of Melzack and Wall and gate control theory. Melzack has said, you don't have to have a body to have pain. So Melzack's point was,
all you need is a brain? Is that what you're saying?
If there is a pain generator, and that's an if, and I'll show you a little bit about that.
Okay.
If there is a pain generator, it's the brain. You guys function in this every day. What do you do when you want to do a procedure, especially if it's a more complicated one? You want to suppress that brain's activity. You want to anesthetize the patient, so for a brief period of time, that brain is not responding to all of these incoming impulses.
Right.
So that's what you do. So you shut off activity to the brain, and then it comes back as you bring them
So
on.
what do you do with the patient that you say, hey, the pain's all in your head?
Okay, I never use that phrase, but if they come and they say, somebody's told me that, then what I tell them is, listen, let me ask you this. Has there ever been a time when you've been watching television, talking to somebody with the kids, the grandkids, on your iPhone, whatever it is, and for a brief period of time, you are not aware of your pain? And they have to say yes, because this happened to everybody.
Mm-hmm.
The next question is, where did it go? What happened to it? You still have the arthritis, you still have your scars, you still have all the things you have when you say, ouch, it's a 9 or a 10. Where did it go? Now, this is one of the things in system theory and quantum mechanics. They indicate that everything is in a superposition, as they call it, until it's observed. And then, and it's a very, very complicated mathematical formula that I don't understand.
Okay.
The wave function collapses and you observe what's there. So, in a sense, this pain is in a superposition state. The person's not aware of it until they come back and start thinking about it. Now, there's a thing called the Zeno, Z-E-N-O, and this is a Stoic philosopher of hundreds and hundreds of years ago. And this effect says that the more often you observe something, the more likely it is to become stable and resist decay and become essentially embedded into the system. We may be doing our patients in chronic pain the greatest disservice we can do to them by having them monitor and evaluate their pain.
Right. By having them focus on it.
Exactly. Because the more they attend to it, and the more they write it down, and the more they talk about it, if this is all correct, the more embedded it gets into the system, and the harder for us to change that.
And if there is a live audience, feel free to type in questions. Maybe Tran can read them. I don't know. If there isn't, that's fine too. But sometimes y'all's questions are much more, let's say, revealing to other people that are watching than mine. Show us some more images.
Yeah.
You know my favorite images, the ones of the people that mutilate themselves or have these complex rituals.
I have some of those that would take a little while to find, but I know those are your favorite. I've sent some to you, and it is interesting that in some of these cases, there are people who have looked at pain and borderline personalities who engage in self-injurious behavior, which isn't painful to them. And it's interesting.
Like cutting and things like that?
Yes, taking a razor, cut their wrist, other things of that nature. And what is interesting is if they happen to have a chronic pain problem, the use of pain medicine may be contraindicated because it suppresses a phenomenon that they need to feel when they cut themselves to help to control what's going on psychiatrically. So by numbing it up with narcotics, they are more inclined to do more of it and more often because
that's why they're doing it to begin with.
They need to have that experience. Now, this was published in Frontiers of Psychology, kind of a theoretical journal in 2017. And this is the normal way we tend to think about pain. So we have a nociceptive stimulus, something that activates it, a pinch, a prick, what have you. And that goes up to the brain. Now, there are things on the right-hand side, deconditioning, catastrophizing, anxiety, depression, that facilitate or make that event stronger. On the other side, there's resilience, social support, self-efficacy, dispositional optimism. If the patient has that, it tends to suppress the intensity of the stimulus. What we were saying is on the right-hand side, and that is, first of all, we're saying pain is a hypothetical construct, which means, contrary to reductionism, it is more than the sum of its parts. You cannot deconstruct it and say, here are all of the parts, because we don't even know what all the parts are. It's got to be more than what is there. So that's why it says mind emergence. You put things together, and it is an emergent phenomenon. It's more than the sum of its parts. So the brain is still there, mental processing, cognitive processing, but instead of the nociceptive stimulus being modulated by all of these arrows, all of these things go directly to the brain. The point here is, in the context of chronic pain, depression is part of the pain. It is the pain. Mm-hmm. It's not just what it does to the incoming stimulus. Depressed people hurt. I wasn't depressed a month ago, I am today, and they will tell you they hurt. There is no activation of the peripheral system, but it is painful. So our supposition is that all of these things here, that if you went and addressed all, you could theoretically ignore the nociceptive stimulus. But if you got rid of or suppressed catastrophizing, deconditioning, help the anxiety, the depression, help self-efficacy, social support, you are treating the pain, even though you're ignoring, you're not even doing anything to the nociceptive stimulus.
And so the problem with medicine in general is, in general, Dan, we want to work down here. And I'm talking doctors, I'm talking medicine in general. And in fact, getting people to work on the non-nociceptive aspects, the depression, the anxiety, the deconditioning. If I said, hey, we need to work on your depression, hey doc, are you saying this is all in my head? It comes back to that. We're not really good, I think, as a society, addressing the mental health aspects of pain and really mental health in general. I think it's neglected.
I agree. And rather than, it's not only the mental health aspects of pain, it is that these things are the pain. The depression is the pain.
You see, and I have a hard time saying that.
Yeah.
I'm so used to thinking in terms of nociception.
Yeah.
I'm so used to thinking in terms of the L5S1 disc, as opposed to thinking about the depression, the anxiety, the lack of social structure.
And the way to think about that is, again, conceptualize and understand whatever is going on does go to the brain.
Sure.
So it's the processing that goes on in the brain that results in the emergence of this thing we call pain.
So how do we address this as a healthcare system?
Ways that we address this, or the way we address this as a healthcare system, is we've got to get people understanding that pain is not a symptom. It is a disease process in and of itself. And just like diabetes and hypertension, it has a variety of constituent parts. Inflammation, obesity, education, depression, all of these are constituent parts of the pain, and they deserve and require treatment in and of themselves. It's not that we're going to treat the nociception and then we'll see what happens with the depression. There may be times, don't worry about the nociception, let's go after the depression and the anxiety. Now,
Sounds like we need to change our society, though.
You need to change a whole lot of it.
How does pain in Japan, let's say, compare to pain in the United States?
It's a good question. I don't have an answer. What I do know is we have to change our concept, and this is going to be very difficult to do because of our good old friend Newton. We are a science-based society. And these concepts are a bit beyond our traditional view of science.
So because they're hard to measure, we don't necessarily want to invest our healthcare resources into treating these issues.
That's part of it. The other part of it is that patient comes in, and I know you see patients and you'll do a good comprehensive workup. And then you start outlining all of the treatments that are available to them. And once you outline all of this, the next question invariably is, what does insurance cover?
Sure.
So most of what gets done in this society is what is paid for and or affordable. And that's what's been driving it for...
But even my evaluation is really built on what does their imaging show, what's their structural data show, as opposed to what's going on in a psychosocial way.
And the stuff that you look at is important to look at. The key is that pain exists in a context. So take the information you're getting and put it in the proper context. Yes, you have this pathology, and this is what this pathology means. But there are other people who have similar pathology, and this is how it affects them. So it is important to put that information in context. The worst thing that can be done, and I've seen it happen many, many times, patient gets an MRI, and the doctor comes in and says, well, there's nothing really here. What they really mean is there's nothing surgical, nothing to operate on that's going to make a big difference.
Sure.
The patient gets the report, and what's in the report? Well, they got facet changes, they got spondylosis, they may have a little spondylolisthesis and degenerate. And so the patient feels like they have been completely misled and lied to, and they say, oh my gosh, I got all this thing going on with my back and my doctor didn't tell me. So I think part of this is putting things in context, helping the patient to be educated, to understand them, what it means to have this.
But we blame the insurance company as a barrier, but I think a lot of times the biggest barrier to getting patients, let's say even into your pain clinic, is the patient themselves.
Is the acceptance of it, that's right.
And I'm what I'm fishing for is how does one overcome that barrier? And there may not be an answer there,
well,
but it's a difficult.
It's a critical question. And we made a stab at this because with a couple of colleagues, you know, Dr. Sinfrini,
yes,
Leanne Sinfrini, she is the lead author, and there are three of us. We were approached by Oxford University Press, who did this book, to do a book that does just that. And this book is a conversation book. This book holds out cases, and there is a running narrative. We put in the book, here's what you might say to the patient. Here's how you might communicate this to the patient. So intended in the book is sort of a how-to get the patient to understand these things.
No, it's not in this book, it's in a different book.
It is not, yeah, it's one, and this will probably, again, be out in the fall. It should be out this time next year. And this is more like an instructional book. It'd be almost like listening to a videotape. How do you approach the depressed patient about putting that in context? What do you say to them? How do you educate a patient about this? How do you get a patient to be involved in this and that and the other? So that's what the book is intended to do, is to how to do that.
That's great. Okay.
But, now, the other thing, and I know you know this because you brought it up more than once over our careers, is people have a sense. And they have a sense when you buy into it. So if the clinician doesn't buy it, if the clinician is just giving out some phrases and doesn't really understand or buy into the concept, the patient will recognize that. So it is important that people who work in the area of chronic pain take time to advance their education, to understand these things, explore these things, and really challenge their own mindset, so that when they're talking about it, and you can tell when somebody believes what they're telling you and when they're just telling it. And so some of the patients, the reason they respond to this the way they do is they feel like the doctors already know what they're going to do, and they just want me out of the office, so they're shuttling me down the road to the mental health guy. So there's got to be, first of all, the clinician's got to believe in this, and then has to impart it in that fashion to the patient. And we've seen more.
We lost our, we lost our thing. That's all right. You'll have to hold it. Can you hold it, Tran?
Yeah.
Do we have any questions there?
Sciatica pain, how to treat it.
Okay. So that, once again, the nociceptive aspect would be to address what's causing the sciatic pain. Is it a herniated disc? Is it inflammation from the disc? Is it a facet joint? Is it compressive pathology? So the nociceptive part of me wants to put medicine exactly where the fire is.
That's right, and that is a very reasonable thing to do, because that's the first thing one has to look at is what is that pathology. Now, it's interesting about the question of sciatic pain, and I have a lot of fun with this in the office, and probably after this nobody will come and see me. Because patients will come in and say, I have sciatic pain. I said, no, don't use those big words. I don't know that stuff. Point. Where is your pain? Patients acquire words but don't necessarily use them in the fashion that we're accustomed to. So it is pretty important to clarify what it means. Now, if this is coming from a professional, we all know that they know what it is. If it's a patient, the point is, okay, where is your pain?
Right.
Is it upper leg, lower leg? Is it medial? Is it lateral? Is it below the knee? And where is that? And gathering that description about what it is. And then you go into what you guys do and do very well, and that is you've got to sort through what is a pathology. Because understand, I kept nociception in there because one of the things I think psychology has done is we have ignored the importance of nociception. Because when you get somebody who has severe complex regional pain syndrome, and that arm is humongous, and any air on it makes the pain, any vibration causes the person just doesn't go anywhere. Relaxation, a few of these things, but until you find something to calm down that sensitivity and to calm down that intensity of that pain, you're going to have a hard time incorporating some of the other things. So that's where seeing all of these components as being potentially equally active, then you go after and say, okay, in this case, the nociceptive part is the driver. We've got to address this, and then we'll take a look at some of the other things. Where in the other thing you might say, okay, nociception is there.
The best description for me for complex regional pain syndrome, which used to be known as RSD, reflex sympathetic dystrophy, was from one of my teachers when I was in residency, and he said, Brad, if you look back at the history of RSD or CRPS, it dates back to the Civil War, and it was known as Weir-Mitchell.
Right.
And Weir and Mitchell were surgeons, and they basically amputated limbs during the Civil War to save people's lives. Now, how did people develop these? Well, they were 15 years old, they were boys, they've never left home before, and they're going off in a war where they're pretty sure they're probably going to die. And they're, of course, very nervous, very anxious, very scared, and they scrape their arm on a branch and get what amounts to a paper cut. And their whole arm swells up, just like you described. Their fingers change colors. It's to the point where they're amputating limbs with these very minor nociceptive injuries. But the key is, brain was in a crisis. And when you think about that, you start to really realize how we as biologic organisms, if our brain is in a crisis, little things become incredibly painful and big things become incredibly painful.
And that's that complex adaptive system. To understand this part, you've got to understand the system. And to understand the mechanics of a car, you've got to know all about the car. It doesn't help if you only know how the gas tank works.
Anyway, I would be remiss if I didn't bring up the opioid crisis.
Sure.
I'm very curious, and I would love to do a whole show just on opiates with you. But I just want to get your take, because I don't think we've ever talked about it. I want to get your take on the opioid epidemic, because listen, you lived through it. We lived through it. It became an epidemic on our watch.
It did.
So
we bear some responsibility.
So I'm curious what your insights into that are.
Number one is, I think it is mischaracterized. We really will not know what we're dealing with until or unless researchers and epidemiologists take patients who are participating in well-managed clinics and settings, who are taking medicine and who are being supervised, who take drug screens, who are being monitored, they're stable and they're functional, they're doing things. Take and separate those folks out and look at the incidence of addiction, abuse, accidental overdose. Take a look at those folks in that population and segregate them from the people who are getting fentanyl-laced pot off the street, the people who are stealing medicines, the people who are going into heroin. And as it stands right now, if there is a death related to an opioid, it goes in, everything goes into that one kettle. And now we're seeing a lot of synthetic fentanyl coming, and that's going to be the big guy.
But how did we get here? How did we get to this point?
It got partly because we did prescribe, I think, more than what should have been. And I think part of the way we got there is we got hung up on pain ratings. And patients learn very fast, even in the hospital. If you need more or want more, you give them an 8 or a 9. And don't give them a 3 or a 4, because it says you got to address it. So part of that, and there's been other people around, some very well-known people, Sullivan and Ballantyne and so forth, who says that the focus on the numerical pain rating is in part and parcel responsible because we're chasing a subjective phenomenon with these narcotics. Number two, I think we forgot basic pharmacology. I think people who are prescribing, I don't prescribe, but I've been around it since 1979. I overlooked it too. When you think about this, and Oxycontin takes a lot of heat from that. But think about it. One of the things that came out years and years ago was an Oxycontin 80 milligram tablet. And at one time there was even 120. But when you think about the makeup of an Oxycontin 80 milligram tablet, and it's really quite small, very small. Now Oxycontin or oxycodone is 50% stronger than morphine. So that 80 milligram tablet actually was 120 milligrams of morphine. Now bear with me, I'm getting there. Morphine and hydrocodone are 1 and 1 in terms of how they equate. So essentially that 80 milligram Oxycontin tablet contained the equivalent medicine to 12 10 milligram Lortab. Now what do you suppose would have happened if at the time the doctors, it all went away and the doctor was prescribing 80 milligrams Oxycontin BID, now is prescribing, I want you to take 12 Lortab twice a day? How many people would have done it? Not many, and not many doctors would have prescribed 24. So what we forgot was to make sense out of what is there. We treated White Lightning, 150 proof, like it was beer that has 8 to 10%.
Right.
We forgot some simple pharmacology, and it was kind of seductive to have that small little tablet that powerful. So what we looked at is we thought, this is really going to get those pain ratings down, but the rest of it escaped. We forgot to put it in context and to look at that. I think the third thing that happened is, unfortunately, there are a few people who are entrepreneurs, look for business opportunities. Pill mills. There are people who will see 40, 50, 60 patients a day. They don't monitor well. They don't keep records. I teach regularly with Richard Tucker, who is 32 years retired, DEA. He has all sort of stories, including a gentleman that was arrested out in California. His office, Starbucks. He had a table in the corner of Starbucks, and a new person, quotes, patient would walk in, $200. He would ask him to stand up, hold up their coat, turn around. He would make a little note, give him a prescription. And every month they came back, $100 or so on the barrelhead.
That's terrible.
Starbucks. And what happened is eventually 3 or 4 of these folks died. The family members started calling attention to it. The DEA and everybody got in, and finally he was arrested and charged. So you have a certain number of people who are going to take advantage of the system. So I think there are certainly factors, and but we just didn't sit down and really think about what we were doing. And again, we lost sight of the fact, and these are the things that I think are important when you're looking at pain. These are what I consider to be key concepts. The expectations, the patient's acceptance. Do they understand, okay, I've got chronic pain, doc, tell me how to deal with it because I know I'm going to have it. FLOP means functional level of pain. That's one of the things I look at when I evaluate people for implants. I ask them at what level of pain would allow you to get up and do things and move around. And if they say, well, my pain's got to be down to a 1 or a 2, they're not going to be a good candidate because it's never going to get there. The ideal one, if my pain gets to a 4, 5, or 6, I can function. Function trumps pain. Nothing political there. It's just that when I look at folks, I want to know about their function. I'm more interested. So when we're doing things, and imagine what would happen to the opioid crisis if patient walks into your office and they've got a legitimate pain, couple of surgeries, scar tissue, they got pathology. And one says, well, this may be an opioid responsive pain. Harry, give me 3 things that if your pain were 30%, 30 to 40% better, you believe you could, even though you got this, things that your pain is interfering. So if your pain were better, you would be able to do that. Give me those 3 things. All right, I'm going to give you some medicine, and I'm going to have you come back next week. And bring your wife back because I want to see if you're doing them. Imagine the difference if Harry comes back and says, I still can't do it. And we say, all right, well, obviously it's not an opioid responsive pain, so we don't need to go further. Let's look at something else. Would change, I think, the entire dynamics if we become more functionally oriented. And of course, an ideal situation, we'd have them go maybe to a rehab therapist, put them on a treadmill, an exercise cycle, and so forth, get a baseline measure, give them the medication during the trial, stimulator, pump, what have you, and see if they can do more. If they can do more, fine. If they can't, let's change the direction. Dispositional optimism simply means there are people who know if they have the skill, they can help themselves. They can get better. And that also goes to psychological flexibility. They are interested in learning other adaptive ways. And resilience, when you do interviews with patients with chronic pain, it's interesting to go back as far as you can. How did they handle the bumps in the road? How did they handle challenges in elementary school, when they were teenagers, in college, when they played, and I know you played at the college level sports, and you had times, I'm sure, that you had to recover from something. That something happened and you had to make a choice. How am I going to go about this? Am I going to call it a day, or am I going to get out there and rebound from it and get over the barrier? So this resilience, this ability to bounce back and come back, and then there's salience, and salience simply is how important is this? And for some people whose lives are not very full, when something happens to them, this becomes their life.
It takes
You've
over.
seen it. That's right. I've seen it. People where their life is their pain. Without it, they might not know how to interact, how to communicate. The only time they get out of the house is going to the doctor or going for something. So the salience and how important is it? And that goes back to what do we talk to them about when they come in? Do we say, well, give me that pain rating? Is it burning, shooting, stabbing? How much of our thinking about it?
Why don't we leave it there? It's okay. So how do people find you again? Dan Doleys.
It's doleysclinic.com. That's